So I'm so very pleased to introduce our keynote speaker this year, Dr. Mike Pratt, who is my friend and colleague. If I had to describe Mike in one sentence, I'd say that he's without question a global leader, tireless in his advocacy and leadership of physical activity and public health. And indeed, he was awarded a 2013 Odyssey Award from ACSM recognizing these accomplishments. I know he has a lot to speak to us in this lecture, so I'm just going to briefly highlight 3 areas of his work to give you an idea of the breadth of his work, the creativity and the impact of the things that he has done. First, he was one of the key investigators in developing the IPAC, the International Physical Activity Questionnaire, which at last count, I found it had been translated into 23 different languages. And it's used by many countries throughout the world, and probably some of you have used it in your work as well. Second, Mike was one of the co-chairs of the 1995 expert panel that developed the new guidelines, or the new generation of guidelines on physical activity and public health, the 1995 CDC ACSM recommendations for physical activity. Prior to that, our recommendations had concentrated primarily on improving fitness, and this was the first of its generation to look at physical activity in terms of public health. And according to Dr. Adrian Bowman, this is probably the most cited physical activity paper, which I think maybe about a month ago when he looked at it, it has been cited more than 8,000 times, which is really a lot. The third area I wanted to highlight is Mike has been crucial in developing capacity for global health research and practice. He is a key player in developing research and practice courses that have been conducted throughout the world, and he personally has directed at least 48 courses in 20 different countries. Currently, Mike is a visiting professor at Emory University, and he's also a liaison to the CDC's National Center on Chronic Disease Prevention and Health Promotion. So I'm going to invite Mike up to the podium now, and he's going to speak to us on the economic cost of physical inactivity. Mike, please.
Well, thank you very much, Imin, for that nice introduction. And you got a little bit of a preview of my talk already, but I'll go back to the first slide. And I am really honored and pleased to be able to give this lecture, both because it is the Morris Paffenbarger Lecture, and those 2 gentlemen are famous in our field as being the fathers of the field. Jerry Morris, especially for his London bus driver and conductor studies and London English civil service worker studies starting in the 1950s, and Ralph Paffenbarger initially for the San Francisco longshoreman study and later the University of Harvard and Pennsylvania alumni studies. And equally, I am honored to be able to follow the line of speakers who have previously given the Paffenbarger-Morris lectures, who are friends, colleagues, and really leaders in this field. I was lucky enough to know Paff a little bit, and you can see him here with a big belt buckle, and those of you who knew him will know that that represents one of his many finishes of the Western States 100, and Paff was an example not only of a true gentleman and a researcher, but a midlife initiation of running, and he did an immense number of marathons and Western States 100 milers. So he's a true inspiration to many of us. I was also really fortunate to be able to work with Paff and Jerry on one paper together. This actually is the paper that I'm in, referred to. It's perhaps this was a good omen that we lined up Paff and Jerry and a rather long list of other authors, and this is the most cited paper in the field of physical activity and public health. So what can I bring to all of this on top of these brilliant forebears? I think the perspective of a simple-minded public health physician, and sometimes simple is good. And I think most of our research in public health comes down to a handful of basic questions, which you can see here. Is whatever it is we're dealing with important, whether it's Ebola or Zika or HIV or physical inactivity? Can we actually do something about it? In public health, we're about not just doing interesting work, but hopefully doing something with it. Is it worth doing something about it? And obviously this begins to bring in, among other things, an economic perspective. What works best, and policy research, how can we make it all happen? And what I'm really going to concentrate on today is the first question and a little bit on the third. Is it important, and is it worth doing something about? Because this is the added value of economic research in a public health arena. So our question for today is this pretty simple one. What's the economic cost of physical inactivity? You might say, well, we should be able to answer that one in 10 minutes. But to give me a little more time to talk and to make matters somewhat more complicated, I thought about what do we really mean when we ask that question, and why are we asking it? So clearly we want to have a better understanding of the full societal impact of physical inactivity, economic aspects as well as health aspects. And in part, we want to be able to do that to put physical inactivity in context with other important public health issues, and potentially to guide decision-making in public health and in public policy more broadly. And for that, we may well want to have some economic information, because at the end of the day, decision-making oftentimes depends on money. And we know that money matters, and we'd like to be able to put it into a context where we can weigh the value of physical inactivity and compare it to other important public health and public policy issues. Now, to the question itself, it seems like a rather simple one, and we presumably will come up with an answer in dollars, but in fact, there are subtleties, as in any area of research, to the question of what does inactivity cost us. Most of the time, when this question has been addressed in research, the question is, what are the total healthcare expenditures attributable to physical inactivity? Sometimes that's worded a little bit differently. What are the direct costs of physical inactivity? With the direct costs generally meaning direct medical costs associated with inactivity. And these two questions give you a hint at what's to come. Some of you will notice the word attributable in there. That gives us a sense of an epidemiologic direction that we may go with in the methodology required to answer the question. But we'll also see over the next half hour or so that even something as simple as defining direct costs can be interpreted differently and can guide us in slightly different valuations of the cost of inactivity. Physical inactivity is not just important because it causes disease and that disease incurs healthcare costs. People miss work, they can be less productive, they can be absent, their caregivers at home may miss work. There can be a number of indirect costs associated with people being physically inactive, and some analyses have attempted to incorporate those as well. And obviously, if we want to get a full picture, we add up the direct and indirect costs, and in some instances we're able to compare in the same data set people who are active versus those who are inactive and look at those costs. An important aspect of this type of analysis from an economic perspective is who's paying. That is, from what perspective are we looking at this issue? And economists like to use a number of different perspectives. As you might expect in public health, we're especially interested in a broad perspective, a societal perspective. However, the reality of most of this work, which in the big scheme we would say we're still probably in the early phases of doing very good economic research on physical inactivity. Most of the work that's been done has actually been done from a healthcare perspective because we're only looking at healthcare costs. And it's perfectly reasonable in this type of analysis to take an employer perspective or an individual perspective. Why does this matter? Because you count different things in different ways depending on who you're trying to ascertain as paying and what the perspective of the analysis is. So what are economic evaluations? This is a definition that is a standard one used at CDC and that I think is helpful to put some context on what we're doing. So these are applied analytic methods to identify, measure, value, and compare the costs and consequences of prevention and treatment strategies and health behaviors like physical activity. And there are a number of different ways and types of economic analyses. What I am going to concentrate on is the first and the simplest one of these, which is a cost of illness or a cost of a health behavior study. You can also look at cost of interventions, and you can look at analyses which balance costs and benefits, such as a cost-benefit analysis, results are all in dollars, a cost-effectiveness analysis, dollars for a given natural health outcome, or you use a calculated variable like disability, adjusted life years, or something similar to that for a cost-utility analysis. It's one of the nice aspects of doing this kind of work is that you get to work with economists. And these are a different sort of human being. They think quite a bit differently than we do, and I think it is a useful thing to bring that perspective to the type of work we do in public health and in clinical research, because the first premise that an economist will bring to the table in a joint project of this sort is the idea that health is only one of many values. And many people in our field will say, without health, you have nothing. Economists would roll their eyes at that and say, no, health is one value, but people make decisions around many other things, and you have to look at what they do in order to understand where they put health in a hierarchy of values. So from an economist perspective, people make rational decisions weighing pros and cons. And yes, there's a new field of economic research in which they acknowledge that people aren't always rational, but in general, classically, economists view people as maximizing utility. They want to get the most value out of their life. They weigh the pros and cons of things, and they make a decision. And the only reason that we should interfere with that decision-making process or the power of the market is if something goes awry. There's an inefficient allocation of resources or an irrational set of decision-making. And from an economist standpoint, this doesn't happen often. When it does, it's either because people don't have the right information, there's a deficit of information, they don't bear the consequences of their decisions, so there's externalities, or there's just a failure of rationality, and usually they reserve that one for children. So children aren't capable of making these decisions. We make some of them for them. We set a driving age, a drinking age, we require them to go to school, et cetera. And there's a few things that are just public goods, defense, education, et cetera. But in general, just because a problem is big, an economist doesn't think it merits public intervention. Most of this is related to cost-effectiveness research, but I thought it was useful to introduce the idea that economists may see the world a little bit differently than we do. And here's an example of that. Now, most of you, being trained health professionals, will examine this picture and identify a number of risky health behaviors here and probably poor decision-making over a course of years. An economist might look at this and say, well, this is a really fine example of maximization of utility. Excellent choice by these gentlemen here. And these are actually the types of discussions that come up in group projects that bring together our two fields. So, on to the real meat of this talk. I'd like to go through 4 examples that bring out what the costs of inactivity are. And I've framed them in the way you can see here, a simple-minded epidemiologic exercise, an elegant 4-part econometric model. Then we will become even more sophisticated. We'll look at the view from Europe. And then finally, we'll begin to take a global perspective. So what do we do in our field when we want to get a sense of what's out there? We do a review article. And thanks to Felipe Lobello in the front row here and a medical student he brought to CDC to work on a joint project, we had the horsepower to do just such a thing a few years ago. And we did a review focused specifically on national cost of physical inactivity. And this is a summary table. You might say, this is a summary table from a review article. There's only 11 articles up there. In fact, there's not a very large body of literature on national costs of inactivity. If you extend that to costs within healthcare systems or in small studies, you get quite a larger body of literature. And in fact, this is a little easier to read, a summary of what we did. As in all review articles, we used a rather extensive set of search terms, brought in a lot of studies, narrowed them down to the 11 that focused on national costs of inactivity. And the last 2 points are the ones I want to concentrate on this slide. You can see that there are national costs of physical inactivity from a small number of countries. The United States, Canada, the United Kingdom, Australia, Netherlands, and Switzerland. And while that set of countries are probably quite well represented in this audience, this is hardly a reflection of the global population. So there are not a lot of studies. None of them are from low and middle income countries. And remarkably, this hasn't been a very popular area to do research in, with no new national estimates cropping up in the last several years through 2014. We also were able to do a little sub-analysis in this project, and really to revive one that had been a collaborative effort with Victor Matsudo's group at Sellafisk a number of years before, to see if the situation in one case looked similar in a low and middle income country. In this case, actually, the state of Sao Paulo, which has about 40 million people, so it's as good as a country. And the approach we used, and the reason I'm going to show this example, is that most of the work that's been done in this area uses what I was somewhat humorously calling a simple-minded epidemiologic approach. And what this is something that the epidemiologists in the audience will all be quite familiar with. It's a population attributable risk or fraction approach. And the idea is to approximate the proportion of a disease that's attributable to a particular factor. And in order to do that, you need to know the prevalence of that risk factor or behavior in the population, in this case inactivity, and the relative risk for the diseases or conditions of interest for the people who have that risk behavior, those who are inactive versus those who don't, those who are active or who meet physical activity recommendations. Using a relatively simple formula, you can calculate the proportion of disease and potentially cost that's attributable to physical inactivity. If you are interested in a lot of diseases and conditions, and obviously for physical inactivity we are, then you can add all these up. And you might say, well, should we not be adjusting this? And yes, we should. And the formula on the bottom is the one that you use if you have the data that allows you to adjust. Most of the analyses that have been conducted, with the very notable exception of Iminli's paper looking at global mortality attributable to physical inactivity, published in the Lancet in 2012, most have actually used the simpler approach, largely because it's really hard to find the data necessary to do an adjusted approach. And this example, in interest of simplicity, is the simple one. So what did we do? We had information on 10 diseases in the Sao Paulo State Health System. We looked at the literature to look at relative risks, and we made the calculations. You can see the 10 diseases and conditions here. You can see that these capture many of the most important diseases for which physical inactivity increases our risk. This is actually an interesting analysis because there are 10 of them there. And you will, as you go through the literature, you'll see that almost all of the population attributable fraction studies rely on looking at the mortality or the cost associated with 4, 5, or 6 of the 22 diseases associated with physical inactivity. And you will immediately understand a limitation that's going to come up in this work from that comment. So 32% of the people in Sao Paulo are inactive, according to state surveys at the time. Went through this process and came up with a number. And as in all economic analyses, you have to put the number in context. It seems like a fairly big number. That makes us happy. We want to think that physical inactivity is an important economic cause as well as a health cause. And in this case, about 90 million reals of medical costs back in 2001, 2002 in Sao Paulo. Importantly, it's about 3% of the public health system healthcare costs in Sao Paulo. That's pretty consistent with the numbers that came out of the studies in the high-income countries, and had a clear limitation that it was only the public system and it was only direct costs. But I think gives a ballpark estimate of the cost of physical inactivity and the fact that they're substantial, that physical inactivity doesn't just matter from a health standpoint, but it matters from an economic one as well. Okay, you may be thinking, well, that's nice, but surely we can do something a bit more sophisticated. And yes, we can. And in particular, if you have a highly motivated and well-trained doctoral student, such as Susan Carlson, who is the tall woman in the middle here, and you surround her with a couple of public health people on her committee and a couple of economists. And if you bring that combination together, you will produce a publication which, such as this one, Inadequate Physical Activity and Healthcare Expenditures in the United States, published in 2015. And I think this is a model for a little more complex and comprehensive approach at understanding the costs of inactivity. And you can make, depending on the data that's available in a number of circumstances, you can make a case for either an epidemiologic approach or a regression analysis approach for generating costs of inactivity. What I'm going to do in this next example is go through a regression approach. And you can see the purpose of the study. It's to look at the influence of leisure time only aerobic physical activity based on current guidelines on direct healthcare expenditures in the US, healthcare perspective, healthcare costs only, and estimate the fraction of aggregate healthcare expenditures that were attributable to inadequate levels of physical inactivity. And one of the real strengths of this study is the data set. It's a nationally representative data set. The National Health Interview Survey is the starting point, and many of you probably have worked with it. It has very solid self-report assessment of physical activity, and it allows us to assess not just active versus inactive, but the spectrum of activity from inactive to meeting recommendations. And importantly, a subset of individuals in the more recent years of HIS have also been included in something called the Medical Expenditure Panel Survey, which is a nationally representative survey of healthcare costs, starting with the individual, going to their provider, and also mining insurance data sets. You can go to their website and get the details on this, but it's a very extensive assessment of medical costs for the very same people for whom we have physical activity data, and this makes it an unusual data set. So Susan carried out a 4-part econometric model to look at these relationships and was able to control for many of the confounders that you would like to control for if you're looking at physical activity and health. And what are the results? So in summary, you can see 2 models here. The top model did not include BMI in the model. The second, more carefully adjusted, including BMI. So I would ask you to concentrate on the second model. And what you see here are 2 sets of numbers with the confidence intervals. The first is the difference in cost per year per patient or per person for the people who are, the reference group are people who meet physical activity recommendations, and then we look at those who are insufficiently active, they get some activity, and those who are inactive. And you can see that people who get some activity but not meet recommendations have healthcare costs almost $600 more than the actives, and it's about double that, $1,300 for those who are inactive. And that represents 12 and 26% increase on top of the healthcare costs for active people. So that's a substantial amount, and if you extrapolate out to the population, you'll see it's more. The second point, which I won't spend much time on, but is really interesting, is the numbers aren't really too different between the model which includes BMI and the model which doesn't, which suggests that most of the costs due to inactivity are not a consequence of people's body weight, they're a consequence of inactivity. So this is essentially a cross-sectional analysis, although those of you who looked carefully at the first method slide may have noticed that the medical costs actually came in the 2 years after the physical activity assessment. So it's a very low-end longitudinal study, or perhaps more accurately, a cross-sectional study. And in this circumstance, we are worried about reverse causality. Perhaps the people who were already sick were simply less active, rather than people who were less active incurring more disease and therefore more health costs. And traditionally, in epidemiologic analyses, to get a sense of whether this is the case, we look for groups that might be particularly high risk for having this. So we take people out of the data set who die in the first year after follow-up, or people who already have heart disease or stroke, or people who already have some degree of disability, some degree of problems with walking. And you can see on this slide that doing these sensitivity analyses, removing that part of the data and reanalyzing it, doesn't cause a major shift in the results. The results are a little less strong, but they're still very much in the same direction and approximate what we saw before. So we think this is a robust finding. People who are inactive have higher medical costs. All studies have limitations and strengths. You can see them here. I won't go through these in detail, but I think the key ones that we should remember are this is cross-sectional data. It is self-reported data, although that would tend to bias towards the null rather than give us an exaggerated association. But it's also a very large nationally represented data set. I don't think I mentioned the final analytic sample is a bit over 50,000 people. So it's a big nationally represented data set. So what do we know about the cost of physical inactivity in the US using this approach? Physical inactivity causes about 11% of total healthcare expenditures in the US. That's more than $100 billion. If we take a very conservative approach and we exclude anyone who reported any difficulty walking, it's still approximately 9% of total healthcare expenditures, and it's about $80 billion. The other thing you may have noticed is that it's somewhere in the 8 to 11% range. This is much higher than the epidemiologic assessments. And why is that the case? I'll get into that a bit in the next slides, but it's an observation, and it's really important in understanding. It's not necessarily one is true and the other is not. These are two different methods which produce different estimates based on the methodology. One, depending on what you think, you might argue that one is closer to reality than the other. I lean towards this as being closer to reality, but other people will respectfully disagree with that. So how does this study compare with previous national estimates in the United States? So these are the studies that I'm aware of that are done at the national level in the US, and have tried to get at much the same question: how much does physical inactivity cost the healthcare system in the US? Graham Kolditz did the first study on this, used population attributable fraction approach, included 7 diseases in it, came up with an estimate back in the late 90s of $24 billion. We did another study at CDC, also using medical expenditure panel survey. At that time, it was not linked with HIS, and so the physical activity question was a very crude one. So a little less optimal data. Our estimate was $76 billion in $2,000. There was an analysis that never saw the light of day at CDC in the mid-2000s that was designed to look at state-specific costs, but of course you can add up the states to get national costs. And that one, using an epidemiologic approach, produced an estimate of $32 billion, and we just talked about the current one that Susan Carlson did. And obviously you can't compare these numbers unless you put them in common dollars. Using the calculator that MEPS recommends to adjust healthcare costs, put these all in 2012 dollars, and what you can see is that they really fall into 2 groups. right along the method used. Something in the range of $100 billion if you use a regression approach, something in the $30 to $40 billion if you use an epidemiologic approach. And aside from the fact that different methods with different data will always produce somewhat different results, I think there's two good reasons for this. The first is that the epidemiologic approach relies on inclusion of diseases for which we have really good data. And of the 22 diseases and conditions which were included in the HHS Physical Activity Guideline Review in 2008, for which there's solid evidence for an association with physical inactivity, usually only a handful of them have enough data to be included in the epi analyses. So you leave out costs associated with some diseases. The second is that the epidemiologic approach is looking at what happens if you can prevent these diseases and doesn't do a good job of factoring in treatment costs. So for some diseases and conditions, so for example, cardiac rehabilitation or treatment of diabetes, there will be a lot of potential savings because people who are inactive cost less to the healthcare system, the people who are inactive cost quite a bit more to the healthcare system once they already have diabetes or coronary heart disease than do those who are active. So there are two different worlds of analyses, but there's some rationale for why they have somewhat disparate results. What happens if we compare physical activity, or inactivity in this case, to other important diseases and conditions? After all, this is one of the reasons we do economic analyses. What you see is it's an interesting picture, and also interesting methodologically. We're looking at physical inactivity, obesity, diabetes, and tobacco smoking. All four of the kind of the standard best estimates come from quite similar analyses that are based on National Health Interview Survey and the Medical Expenditure Panel Survey. And physical inactivity, while not as costly to the healthcare system as obesity, diabetes, or smoking, is right up there. It's a very important cost to the healthcare system in the United States, even if not quite as much as some of the other well-known chronic diseases and conditions. Okay, let's move on briefly to other parts of the world. What's the situation in Europe? There was a report published in June of 2015, really trying to get at these same issues I've just been talking about in the US. We know physical inactivity is a terribly important public health issue. Is it costing us economically? And to jump to the conclusions, here you can see them. Similar approach, epidemiologic approach, 5 diseases and conditions included. This time an interesting addition. This analysis included disability-adjusted life years to get at indirect cost as well. And their estimate was that inactivity cost Europe 80 billion euros a year, about $100 billion. So this seems very consistent. The interesting result here, which may make you scratch your head, is the apportioning of the cost to direct versus indirect. And what you see is that the vast majority of these costs are felt to be from indirect costs. Good question. Their methods are a little hard to sort out, so I'm not going to be able to give you a satisfying answer on this. But I think a really important one is that mental health, all of the costs associated with mental health fell into the indirect cost area. And you could very easily pile many of those costs into direct costs in a different analytic approach. Another important point that you see in this analysis is what do you do with this data? Why do we come up with a big number? Inactivity costs Europe a lot. What does that mean? And I think the last point on this slide is an example of how this type of information can be used. If we can reduce the prevalence of physical inactivity in Europe, it will save 16 billion euros every year. And so this is a rational use of the data. We know it's unrealistic to get everyone who's inactive to become active, but getting 20% of the people with a very good health promotion programs might be feasible and would lead to substantial healthcare cost savings. This was an interesting analysis because they looked at 6 different countries as well as Europe as a whole. I showed this example from Spain just to bring out 2 other important points. The last 2, again, a really interesting use of the data. 13% of the deaths in Spain are attributable to physical inactivity. If you are a health minister or a regional health officer, and you know 13% of the deaths in your jurisdiction are just due to people being physically inactive, this suggests public policy intervention. You can do something about this. It's a lot of people, a lot of deaths, and we have some information on how to get people more active. The second point is that they specifically looked at the disability-adjusted life years lost. So this is really looking at issues of lost productivity and mental health. And I think it's a hugely untapped area in physical activity and health research. Mental health is clearly one of the most important benefits for physical activity. And we have some data in that area, but it's nowhere near as well explored as, say, diabetes or cardiovascular disease or breast and colon cancer. So a few methodologic observations, because as you have gathered from this presentation, I think that the methods that we use to explore these issues have a very big influence on what the results look like and should be taken into account when we interpret those results to guide public policy. So one of the first things is that the physical activity data we have first makes these analyses possible, but it also guides them in particular directions. And if we can only classify a population as active versus inactive, we'll get rather different results than if we can look at physical activity as a continuous variable, or we can even incorporate the somewhat increased health risks and presumably costs of people who are in that intermediate category. They don't meet recommendations, but they get some activity. How many diseases do we tally up the costs for? It doesn't take an epidemiologist, although we love to count things, but it doesn't take a really sophisticated epidemiologist to think that if you count up the cost for 5 diseases, they might be less than if you counted them up for 22. And what are the costs of those diseases? Do they vary by country? Do they vary by healthcare systems? What do we put into the direct and indirect buckets? And then the last point, which I'm going to touch on my final global example, which is quite important in interpreting them and was really very interesting in the European example, is that the overall economy and healthcare system in the country makes a very big difference in the numbers we come up with. So the same pattern of disease in the UK will produce much higher healthcare costs than in Poland. And that's simply because the GDP in the UK is higher and the healthcare system is different. So, a brief promotional interlude here. Coming soon, July or August, the launch of the 2nd Lancet Global Physical Activity Series. Data embargoed, still not quite ready for prime time. However, you can see that a team of researchers led by Melody Ding from Adrian Bowman's shop in Sydney is writing a paper, The Economic Burden of Physical Inactivity, an initial global analysis of major non-communicable diseases. You can probably immediately tell from that title, this is a population attributable fraction approach, and it's going to be a first stab at what physical inactivity costs the world globally. And very interesting, it's going to involve more than 90% of the world's population, 140 countries. The data is not quite what you would like to have, but in public health and public policy, we have to make do with what we can. Keep an eye out for this series, a very strong group of authors producing papers in several areas. I'm only really promoting the global economics one. And a couple observations from this, because I think they're relevant to the data I've presented, and they're important in understanding the challenges we have ahead of us in doing this kind of work, and the care that we have to take in interpreting it. So first, Very few countries have the kind of data that Susan Carlson was able to analyze in the United States, where you have a large nationally representative data set with data on, pretty good data on physical activity and solid data on medical costs. Now you might say, well, perhaps somewhere out there, there is a large cohort study in which people will be followed for many years. At some point, they will introduce accelerometry, objective measures of physical activity into that, along with questionnaires, and follow those people for a long time and get their healthcare costs. And yes, that's what we would really like to have in this area, and probably we will eventually see. So far, nothing quite like that has been published. I think one of the most interesting observations from this work in progress is that most of the global morbidity and mortality and disability adjusted life years from physical inactivity come from low and middle income countries. Those of you familiar with the global health literature will probably know the phrase that's in the first paragraph of everybody's paper these days. 80% of the mortality from chronic diseases comes from low and middle income countries. Well, not surprisingly, you would expect then that a lot of the cost comes from low and middle income countries, but that's not the case. Most of the costs come from high income countries, and especially from the United States. So one of the great things about having a phenomenally inefficient healthcare system is you could pile up a lot of healthcare costs with a modest amount of disease. And you may say, well, yeah, so I understand that might be important, but it's worth looking at some data from a very interesting paper published by a health economist at CDC, Ping Zhang, in 2010, looking at global costs for diabetes. And it gives you a sense of this disconnect between burden of disease and cost, and why we have to be careful in interpreting our cost data. So what you see here are just 5 countries pulled out of a much larger data set, and some of the data, looking at the cost in US dollars per annual cost per person with diabetes, and then looking at the percent of total healthcare expenditures. First, to the healthcare expenditure side, you can see that they're different but all substantial in each of the countries here, but that the costs are remarkably different. In the US, we spend a little over $7,000, that we did back in 2010, per person with diabetes in the US. So not surprisingly, since we spend about twice the GDP that Germany does on healthcare, Germany spends about half that, so $3,700 per patient. But those same people with diabetes in India and Nigeria show up at a much lower level in our economic analyses because the costs are 100+ less than in the United States. And so I think this is a really interesting observation and a caution that we have to balance morbidity and mortality data with economic data to really understand the total societal burden. So to wrap up, in conclusion, physical inactivity costs us a lot in the United States, something in the range of $100 billion a year, about 10% of healthcare costs, if you fall into the regression analysis count. Costs in other high-income countries are in the same proportional range, less because their healthcare systems are less costly, but they're comparable. But in low and middle income countries, it's very challenging to calculate costs, thus we don't see many examples of this being done, and it's probably equally challenging to interpret what that data means. And as an epidemiologist, I will come back to methods matter. They matter a lot, not just in the quality of work you're doing, but in how you interpret it and how you turn the research into public policy. And finally, we don't really have that much to work with when we look at the national and global costs of inactivity. And you could see that I was drawing on a handful of studies for this presentation, but if we take a more recent example of the 675 abstracts which were submitted for the International Physical Activity Congress coming up in November of this year, only 10 of those 675 focused on economics. So there are not a lot of people doing this work. Those of you who are early in your careers or ready for a change might see this as an opportunity. There's a lot of good work waiting to be done, a lot of challenges in this area. And yes, there are truly some pretty big challenges in doing important public health work. We need to carefully choose the research method to match the available data. And as you've seen, we can't always use the approach we might choose to because it depends on what data is available. I didn't touch much on indirect costs, and there's more to be done there if, in many different ways. There are a handful of countries, the Netherlands probably foremost among them, where there's been very interesting work and provocative work in this area, which suggests that it's just as or more important than the direct healthcare costs. I think the greatest need for this type of work, both from a research standpoint and to inform public policy, is in low and middle income countries, but we have the least data and the fewest people working on this there. So big challenge. We really need to keep in mind a point that I've been beating home the last few slides, that health and economic burden are not proportional, and we have to think about them both. And the next point is my own personal opinion here, but it seems to me that we have placed relatively little value on this type of research, and partly as a result of that, and partly as a result, or maybe despite it, of the complexity and the policy relevance, there's less of this research than you might think should be there. And I think that's a challenge. Maybe we need to reposition this work as well as generate the capacity to do it. And finally, we do have to get these two rather different sets of human beings, epidemiologists and economists, health people and economists, working together to do this fairly complicated work. So I'll come back to where I started. Here you see Ralph Paffenbarger and Jerry Morris in 2002, when they were at a very ripe old age. And you may have noticed that they were still very productive late into their careers. So I think they are a great example to us of two guys who invented a field of research, who overcame challenges, and were productive for many decades. And so perhaps we can take a lesson from that and say we're at the beginning phases of doing some really interesting and strong work in the economics of physical activity. If we can just take it on like Paff and Jerry, perhaps we'll get somewhere in another 50 years. So thanks for your attention. It's really a pleasure to be here.